All right, I think we are at the witching hour of 8 a.m. So welcome everybody to Grand Rounds. I hope everyone had a restful and happy Thanksgiving holiday weekend, whether you were working or with family or just hanging out. Delighted to have Jessica Tischendorf today as our featured Grand Round speaker, and introducing Dr. Tischendorf is Dr. Dave Andes, our division chief for infectious disease. So Dave, take it away.
Thanks, Dr. Schnapp. It's my pleasure to introduce our own Dr. Jessica Tischendorf. By way of introduction, she completed her undergraduate degree at UW-Eau Claire before moving to Madison, where she completed her MD, Master's in Education Leadership, and fellowships in infectious disease and women's health. After which we were fortunate enough to recruit her to the division. She's a superstar clinician educator, and most recently is leading our ID fellowship program. The topic of her presentation today is quite timely. Today is World AIDS Day, and improving the care that we provide to persons who inject drugs is a critical step in ending the HIV epidemic. So I'm excited to learn how we can optimize care for these patients. So Jess, looking forward to your presentation.
Thank you for that introduction, Dr. Andes. I'm confident that all of you, no matter your practice setting, have the opportunity to interface with patients with substance use disorders. And over the next hour, I want to give you some language to better relate to and to better educate your patients who inject drugs specifically. For those of you who do not encounter patients who inject drugs, I certainly hope you can at least take away some information from this talk that will make you a better informed citizen, one that's more capable of helping to care for this vulnerable group in our society. I would like to disclose that I am a co-PI on a research grant through Merck for unrelated work, and that I will be referencing unlabeled use of drugs in my talk. Admittedly, I think like many of you, I struggled during my training to provide empathetic, well-informed care to persons who inject drugs. They simply challenged my comfort, and the limitations in our ability to routinely provide standard of care frustrated me. I'm not proud that I have this perspective, but I do know that I'm not alone in sharing that perspective. And this really changed during my first year on faculty. I was pregnant with our second daughter, and there are two patients, two young parents I cared for, who I will never forget. The first was a young woman who was admitted with Staph aureus endocarditis and vertebral osteomyelitis at 4 weeks postpartum from the birth of her first daughter. She had used injection drugs up until a few weeks prior to delivery, but since the arrival of her child, she'd maintained a several-week period of abstinence, leaning heavily on the support of her mother, with whom she and her newborn were staying. Owing to the very complicated nature of outpatient IV antibiotic planning in persons with active substance use disorder or those in very early remission, she remained in the hospital and an LTAC setting the entire 6 to 8 week course of her antibiotic infusions. And understandably, this caused her a great deal of distress being separated from her newborn that long. The second patient was another young man who'd been in sustained remission from opioid use disorder for more than 6 years. His recovery initially precipitated by the arrival of his first child. He'd recently learned from his now 6-year-old son's mother that he was not the paternal or biologic father of his son. And this precipitated an acute stress reaction, triggering resumption of injection heroin use. He had also Staph aureus endocarditis that had seeded his CNS, and again, remained in the hospital for a couple of months getting IV antibiotic infusions. During that time, unable to access the support of his family and his community to assist in coping with the traumatic news of the paternity of his son. These were among the first patients with active substance use disorder who I felt personally connected to, really able to relate to the joy and the heartache and the sacrifices that they were making as young parents. And since that time, I've continued to improve my capacity to provide non-judgmental, patient-centered care for persons who inject drugs, and really view hospitalizations and ambulatory visits as opportunities to help counsel them to prevent further infectious complications. I will also disclose I am no expert. I am learning. There are individuals in my division, my colleagues in addiction medicine, who are far more expert. I simply endeavor to be a better doctor for this group of vulnerable patients, and I hope today I can empower some of you to do the same. I have 5 goals for our time together today. First, appreciate the frequency of substance use disorder in Wisconsin and the scope of injection-related infections. Seek to understand motivations and desires of patients who inject drugs when interfacing with healthcare. Develop accepted vocabulary for speaking to and about persons who inject drugs. Familiarize yourself with harm reduction strategies you in turn can then share with your patients who inject drugs. And develop greater comfort offering HIV pre-exposure prophylaxis or HIV PrEP for persons who inject drugs. I suspect it comes as no surprise to those of you joining today that the scope of injection drug use and the associated complications is enormous and it's growing. These are recent data from the CDC showing the rate of drug overdose death over the past years. As I think you can appreciate, this rate has grown exponentially over the past 10 years and accelerated even further during the pandemic. We are certainly not immune to these trends in Wisconsin. You can see in these data going back to 2014 that our rate of overdose death has been steadily climbing. And the trends we see are similar to those that are observed nationwide, with the majority of overdose death attributed to opioids, largely now attributed to fentanyl. And alongside this risk of overdose, we've seen a concomitant risk or a concomitant increase in the infectious complications of injection drug use. And of course, one of the reasons I, as an infectious disease doctor, care so deeply about this crisis. Persons who inject drugs are at risk of complicated bacterial and fungal infections, including bacteremia, endocarditis, epidural abscesses, septic arthritis, very complicated injection site infections such as skin and soft tissue abscesses, wound infections. There have been several case series of the transmission of botulism and tetanus through contaminated drug supply. We observe a higher rate of tuberculosis among persons who inject drugs, likely mediated by an increased risk of homelessness or congregate living. We also observe a higher rate of sexually transmitted infections, gonorrhea, syphilis, chlamydia. Rates of viral hepatitis are much higher among persons who inject drugs. And indeed, recent data from Wisconsin DHS would suggest that the majority of hepatitis C virus transmission in the state now is attributable to injection drug use. And pertinent to our discussion today on World AIDS Day, a high risk of transmission of HIV. These are data from the CDC that would suggest at least 10% of new HIV cases each year are attributed directly to injection drug use. Syringe sharing is second only to receptive anal sex in the risk for HIV acquisition. And an important mode of transmission for us to consider being that about a third of individuals who inject drugs report sharing syringes or sharing paraphernalia. We've seen new HIV diagnoses in Wisconsin largely stagnate over the past several years. Like nationwide trends, male-to-male sexual contact remains the most frequent mode of transmission in Wisconsin. Injection drug use alone attributed or implicated in about 6% of cases, though this method of transmission is higher in our Native communities. And in a 2019 study conducted among those living with HIV in the state of Wisconsin, 16% had indicated injection drug use as a possible mode of transmission. So certainly something we need to address if we're going to address the HIV epidemic. As I shared with you a moment ago, we observe a high prevalence of bacterial and fungal infections related to injection drug use. We have seen injection drug use associated infective endocarditis rates really grow exponentially over the past 10 or 15 years. And injection drug use infective endocarditis now comprises probably at least 30% of infective endocarditis cases in the US. I did a quick ClickView search last week, and that data holds for UW Health. So somewhere between 30 and 40% of the cases of infective endocarditis that we cared for in 2022 were attributed to injection drug use. And then we also, as I mentioned, observe a high prevalence or incidence of skin and soft tissue infection. We know that persons who inject drugs with these serious infections are more likely to present later in their disease course due to attempts at self-treatment or trying to avoid interfacing with the health system. They're more likely to be uninsured or publicly insured, and they're more likely to be unhoused. There's been a lot of qualitative research that's been dedicated to identifying barriers to persons who inject drugs getting the care that they need. Chief among these barriers is stigma and negative provider interactions. There's anxiety when interfacing with the healthcare system. Certainly one's severity of dependence can inhibit their ability to access care. Competing physical, psychosocial, or mental health needs, high rates of comorbid psychiatric disease, and then the logistical barriers of cost, transportation, and childcare. I'd like to provide you all today with some language and strategies to help mitigate the influence of negative provider interactions in our healthcare system. And to do that, again, we'll seek to understand the experience of persons who inject drugs when they interface with healthcare. We'll review preferred language. I'll share with you some community resources and harm reduction counseling education you can share with your patients. We'll discuss further steps to prevent infectious complications and then end by highlighting the importance of substance use disorder treatment. So first, to better understand the patient experience. While not the primary focus of my talk today, there has been a lot of qualitative work done examining the experience of persons who inject drugs who elect to discharge before medically advised, what is more commonly referred to as against medical advice or AMA. While inpatient focused, I think many of these same experiences hold in our ambulatory environments and still wise to share with you all today. Chief among the concerns of persons who inject drugs in the inpatient setting is inadequate pain control and inadequate control of withdrawal symptoms. They routinely describe a sense of isolation and being policed by hospital staff. And then again, the logistical barriers of finances and childcare. And to share a few epitomizing quotes, this is from a patient who is being cared for in the emergency department. I had an abscess on my head. My whole face was swollen. I was in a lot of pain, and they would not give me any pain medication because I have an opiate problem. Your arm has to be like ripped off before they'll give you a Tylenol. In regard to her experience with her withdrawal symptoms in the inpatient setting, this patient shares, it's not just a fear, it's that you become physically like crippled and sick from the withdrawal of opiates and methamphetamines. Diarrhea, vomiting, sweats, chills, it's just like the flu times 10. I would rather go through childbirth, honestly, than withdrawing. So it's not that I want to get high, it's that I have to. It's become a necessity or I'm dying. It feels like I'm dying. And then in regard to experience with staff in an emergency department, this patient shared, in general, they tend to be a little stricter with you. They tend to be more short-tempered with you. They tend to presume what you need instead of a conversation, right? Fortunately, these patients have also shared with us ways we can improve their experience when interfacing with healthcare, provide caring, non-judgmental staff, provide personal choices in their care, provide access to medication for opioid use disorder if that's relevant and desired, have providers that understand substance use disorder and work together in a coordinated, timely fashion, offer peer support in the hospital, and offer effective withdrawal management and mental health support. We know on the provider side, there are also a number of barriers to providing high quality care to persons who inject drugs, including burnout, a lack of knowledge of substance use disorder, and biases, both implicit and explicit. I want to call attention next to one manifestation of our bias, the language we use when describing patients with substance use disorder. The reason I think it's important to be mindful of our language, of course, is not just the betterment of ourselves or projecting inclusion of those with substance use disorder, but we know the use of stigmatizing language impacts the quality of care we provide. There were 2 small randomized controlled trials that showed when providers were presented with case studies that used language indicating someone was a substance abuser, those people were assigned more blame and negative perceptions than those who were described as having a substance use disorder. So stigmatizing language in these small RCTs was associated with a greater assignment of personal culpability in their health outcomes, and this greater stigma is associated with a lower quality of care. This is a very recent study published in the Journal of Hospital Medicine that showed this association. The investigators here reviewed 300 discharge summaries of patients with substance use disorder, and they found that for those patients who had person-first language included in their discharge summary, those individuals were more likely to have an opioid use disorder treatment plan and more likely to have addiction-specific referral at the time of discharge. Now, I completely recognize this is correlative and not causative, but I do think we can all go a long way in changing the language we use to promote greater acceptance of patients with substance use disorder and to decrease the triggering of our implicit biases during their care. And some of these words to avoid may not be so obvious. This comes from an NIH campaign titled Words Matter. It's available on that website below www.drugabuse.gov. And as part of this campaign, the NIH offers several preferred alternatives. And what I think you can appreciate when reviewing the preferred alternative is that we are describing a person's behavior, not the person themselves. So instead of describing someone as an addict, describe them as a person with an opioid addiction, or instead of saying someone is a drug abuser, a person with a substance use disorder. You describe the behavior, not the person. Next, I'd like to share with you some local resources we have available in Madison-Dane County, as well as some practical advice on how you can advise your patients on harm reduction when injecting drugs. And I intentionally want to center this discussion in harm reduction, which is defined by the Department of Health and Human Services as helping people where they are without judgment, stigma, or discrimination. This is not about changing risk behavior. It's about making this behavior safer. And the reason I think it's important that we talk about this as providers is that formal training in harm reduction is not standardized. This is not an ACG&E core competency that we can be assured all of our residents and fellows graduate from training having received. And there have been several studies that documented providers and trainees alike lack comfort in counseling persons who inject drugs in harm reduction. And to highlight some fresh local data to emphasize this, This is a picture of Dr. Rosemary Bailey, who's one of our outstanding second-year infectious disease fellows. And I have the privilege of working with her on an education innovation project seeking to optimize infectious disease screening, harm reduction counseling, and HIV prevention counseling among persons who inject drugs who are admitted to our general medicine teaching service. This is a mixed methods education research study. She started by reviewing charts of patients with serious injection-related infections in 2022. I'll share those data with you momentarily. This was followed by a survey of our internal medicine residents, which just closed on Monday, so I don't have full analysis available for you, but I do have some preliminary data to share. This will soon be followed by semi-structured interviews of residents to identify barriers and facilitators to optimizing care of persons who inject drugs in the hospital, and then culminating in what we hope to be an impactful education intervention. So what Dr. Bailey found was that in 2022, there were 44 patients with serious injection-related infections admitted to UW Hospital. And this was all comers, not just our teaching services. Among those patients, just a bit over half were screened for HIV and hepatitis C during their index hospitalization. Very few had screening for sexually transmitted infections. I was quite pleased myself to see that harm reduction counseling was documented for 70% of these individuals. But really where we observed the gap was that of 36 of these 44 patients who met criteria for HIV pre-exposure prophylaxis, HIV PrEP, none had discussion of PrEP documented or had PrEP prescribed. So to begin to understand this gap in implementation, Dr. Bailey followed this with a resident survey, which again just closed on Monday. She had 58 respondents for a 56% response rate, well distributed across the PGY training levels. Our residents widely recognized the importance of HIV prevention education and HIV PrEP education for persons who inject drugs admitted to the hospital, with 88% indicating HIV prevention education is very or extremely important in the hospital setting, and 84% indicating PrEP education specifically was very or extremely important. So our trainees clearly recognize the importance of these interventions, but again, there remains a gap in implementation. So we went on to explore this further. We asked the residents about their familiarity with harm reduction resources or practices, safer injection counseling, syringe services programs. I think what you can appreciate is that very few of our residents feel comfortable or feel familiar with these harm reduction resources and practices. We went on to then ask the residents how comfortable they felt counseling persons who inject drugs on these practices, and even fewer displayed comfort translating their knowledge into patient counseling. We also assessed comfort in prescribing HIV PrEP, and we asked the residents to comment on their comfort in prescribing based on sexual risk factors, and we asked them their comfort in prescribing based on risk related to injection drug use. The responses for sexual risk factors is depicted here in red, injection drug use in orange. And I think what you can appreciate is that there's greater comfort in prescribing PrEP for sexual risk factors than there is for individuals who inject drugs. But the good news, and why I chose to speak about this today, is that educational interventions have been shown to improve knowledge and comfort in counseling on harm reduction and offering and prescribing PrEP. So to level set, what I mean when I talk about harm reduction, a multimodal approach to overdose prevention, which includes the wide availability of fentanyl test strips to test one's drug supply, ready access to syringe services programs, which can provide safer injection kits or safer smoking kits, counseling patients on safer injection, offering HIV PrEP, and keeping patients up on vaccination and infectious disease screening. So to share with you some local resources that can help you achieve this, first, I want to highlight naloxone, the opioid overdose reversal drug, within the past year or 18 months, is now available over the counter. No prescription is required. And it's recommended not only for individuals who use opioids, it's also recommended that individuals who live with, frequently interact with individuals who use opioids, or those who might find themselves in a position to intervene during an overdose carry naloxone or Narcan with them. Available over the counter, as I said, for at a cost, but also available free at many community sites in Madison and Dane County. This is an example of expanding the accessibility of naloxone. This is a photo of an opioid overdose reversal box, several of which, more than a dozen, have been installed on the UW-Madison campus over the past couple of years. The image on the left here is taken from DHS. This is the statewide availability of fentanyl test strips. Quite privileged in Madison to have at least 2 sites now that individuals can access fentanyl test strips at no cost. Madison-Dane County Public Health and Vivint Health. And again, this simply depicts that on the right here, naloxone is very widely available now that it's been made over the counter. Many community and retail pharmacies stock it. DHS has a program on their website that actually direct mails naloxone to individuals who are interested. And this, I was at Hilldale Walgreens with my 5-year-old getting her COVID vaccine last week, and was happy to see that this was displayed quite prominently in the pharmacy there. This is over-the-counter naloxone display. We're quite lucky in Madison to have several sites through public health, Vivint, community pharmacy for syringe services programs. And again, what I mean by this is a site where individuals can go in, access harm reduction counseling, but also can access the materials required for safer injection and safer smoking. And there was a study of individuals who use injection drugs in the state of Wisconsin recently that actually reflected that we are doing quite a good job educating our community on these resources. More than 85% of individuals who injected drugs in that survey were aware of where they could access safer injection supplies and felt comfortable doing so at those sites available to them. I'd like to spend some time providing you with some practical advice on how you can counsel your patients on safer injection. And for those of you who anticipate integrating this into your practice, this is a very helpful resource available at harmreduction.org, safety manual for injection drug users. I recognize that is not person first language, but this is actually available in a PDF that you can simply print off and provide to your patients. I'll take you through each of the steps detailed in this manual of drug preparation and injection, because I think it's helpful to understand the risk of infection at each stage, and it allows you to better educate your patients on safer injection and assess their infection risk should they present to you with concerns for an infectious complication of injection drug use. So first, we'll talk about proper material selection, counseling on how to properly prepare an injection, choosing and cleaning the injection site, and then inserting and removing the needle. Another big reason why I think knowing these details is important as an infectious disease doctor specifically is that each of these practices can inform pathogen risk when someone gets sick. So for example, individuals who are using non-sterile water for drug dissolution can be at increased risk of waterborne gram-negatives, which would inform our antibiotic strategy if someone were to present requiring empiric antibiotics. Candida albicans infections have been associated with individuals who use lemon juice for dissolution. Some persons who inject drugs use saliva to either cleanse the needle or lick the needle to check for burrs in the needle before injection. And that, of course, would increase the likelihood of infection with oral flora. And then, as I shared with you early on, needle sharing and injection equipment sharing, of course, is high risk for transmission of HIV and the viral hepatitis. So this photo here that you see on the right was provided to me by Madison-Dane County Public Health. This is the contents of a safer injection kit that they provide individuals who visit the syringe services program. I think what you can appreciate is that a component of this kit is clean needles and syringes. It's preferred for individuals to use insulin or tuberculin needles, very small gauge, short needles, as opposed to needles that might be larger bore or those that are longer. For individuals who share needles or syringes, the larger bore or longer needles can carry more blood in the hub and likely increase the risk of transmitting bloodborne pathogens. And then for those that do not have ready access to single-use sterile syringes, important to counsel them on ways they can mitigate that risk by flushing with cold water or using bleach or hydrogen peroxide to sterilize the equipment the best they can before reuse or sharing. The photo you see on the right here is an individual drying up drug. So this green little cup with the handle is a sterile cooker. This is what is preferred and is provided by many syringe services programs, including Madison-Dane County. For folks who don't have access to sterile cookers, you can advise them to use a spoon that's been sterilized or a bottle cap with a bobby pin or a paper clip attached, really with the purpose of that being avoiding any burn injury while an individual is heating their drug. Sterile sealing is preferred for drug dissolution. I've got several alternatives listed there as well, but advising individuals to the degree that they can, avoiding obviously contaminated water and avoiding the use of saliva, again, either to cleanse or to dissolve drugs. Some drugs require acidification to dissolve. Many syringe services programs provide small packets of citric acid or ascorbic acid for this purpose, avoiding, again, lemon juice or vinegar due to pathogen transmission or vascular irritation. And then what I hope you can appreciate is that this individual is drying up their drug through a very small white pad. This is a sterile filter, which is recommended. If folks don't have access to sterile filters, you can advise them to use cotton personal hygiene products, cotton balls, Q-tip cotton, tampons, really avoiding filter materials that might introduce vascular irritants like cigarette filters, and avoiding injecting crushed fills directly because it is likely to damage the endothelium and may increase risk of infection and vascular injury. When advising patients on choosing an injection site, the antecubital fossa is preferred. It's among the easiest sites to access, among the easiest sites to cleanse, and among the lowest risk for arterial injury. There is likely some benefit in advising your patients to rotate injection sites to avoid repeated vascular injury as well. For those who can no longer access their antecubital fossa, hands, lower extremities would be next most preferred. And really, because of not just infection risk, but also the risk of arterial injury, advising patients to avoid injection into the neck, wrist, or groin. Many syringe services programs provide alcohol wipes or hexidine wipes as an alternative, and then share with patients the benefit of using tourniquets hydration, gravity, heat packs to increase vein visibility and increase the likelihood that they access vein instead of soft tissue. There are 3 techniques of injection that I'd like you to be aware of. The one that we probably think of most commonly is referred to as mainlining. This is intravenous injection. This carries the greatest risk of overdose and the highest risk for endocarditis. Also to be aware of muscle and skin popping. So just what it sounds like, injection into the muscle or injection into the skin. These have a slower onset of drug delivery, so lower risk of overdose, and as you might hypothesize, a higher risk of skin and soft tissue infection. Advising patients on proper needle insertion technique can also avoid vascular injury. So bevel up, angle 15 to 35 degrees, and advising them to pull back on the syringe, make sure they are accessing venous blood, dark red blood, as opposed to bright red arterial blood before injecting. And then finally, they should be removing the needle at the same angle it is inserted. They should be applying immediate pressure using a dry swab, carry Band-Aids, gauze, or tissues, and then because alcohol swabs can impede coagulation, should be advised against holding pressure or cleansing the insertion site with alcohol swabs after injection. We can take further steps when persons who inject drugs interface with the healthcare system to screen and prevent for infectious diseases. And I posit that we should all be aware of these screening recommendations, no matter our practice setting. Inpatient, we have a relatively captive audience where we can quickly update screening, update immunizations if they were to agree. In the ambulatory setting, we know it takes a lot for an individual with an active substance use disorder to present to ambulatory care. So I encourage you to maximize the yield of those visits by implementing some of these screening and prevention recommendations. So recommendations for infectious disease screening largely follow what I shared with you regarding their risk of infectious diseases, frequent HIV screening, not just laboratory, but also assessing for acute HIV infection symptoms is important. Screening for hepatitis B immunity, immunizing if they're not immune, screening for hepatitis C virus at the initial visit, as well as frequently thereafter. Because of the high risk of co-occurring sexually transmitted infections, important to assess for their presence at intake, as well as more frequently based on risk. And then again, being that there's a higher observed rate of tuberculosis among persons who inject drugs, important to screen for latent tuberculosis at initial visits or during an index hospitalization. Because of the difficulty accessing care, this is a group of folks who you're likely going to have higher return on LTDI screening with quantiferon gold over placing a PPD. Individuals who inject drugs should be vaccinated for hepatitis A and B. There have been several hepatitis A outbreaks associated with injection drug use. Annually vaccinated for influenza and COVID, as we all should be. And then ensuring that they're up to date on their tetanus vaccination is also important, particularly if they have experienced skin and soft tissue infections in the past. And where I'd like to focus the next part of my discussion is on HIV pre-exposure prophylaxis, because many persons who inject drugs are eligible for PrEP. What we know from a survey done in Wisconsin is that only no more than 20% of patients who are eligible for HIV PrEP, whether that is through sexual risk or risk through injection drug use, are taking it. So our PrEP coverage right now is indeed suboptimal. And to level set here, I want to just take a moment to contrast HIV PrEP with HIV post-exposure prophylaxis, or HIV PEP. So HIV PrEP is a daily oral medicine, or relatively newly, a bi-monthly injection to prevent acquisition of HIV among those who are at risk of HIV. It's historically been approved for those with sexual risk factors for HIV transmission, but is widely recommended for those who use injection drugs. And this recommendation is at least somewhat based on a large randomized controlled trial that was conducted in Thailand 10 years ago, randomized 2,400 patients to tenofovir PrEP versus placebo, and found that among patients who injected drugs within the past 12 months, who took tenofovir PrEP and were highly adherent to it, there was a 74% reduction in the risk of HIV transmission, with many of the patients followed out to 3 or 4 years. Contrasting this to HIV PEP, this is a 3-drug HIV regimen, which is taken within 72 hours of a possible HIV exposure, taken for 28 days after an exposure. So many of our patients who inject drugs would be eligible for both HIV PrEP and HIV PEP, but I will not be focusing my discussion on HIV PEP. Instead, I do want to provide you with this consultation line. This is run through UCSF, the National Clinical Consultation Center, what we refer to as the PEP line here, has hours, 365 days a year, weekends, holidays, where you can call an expert in HIV PEP to get advice on regimens you should be prescribing to people. So as I said, PrEP is now widely recommended for persons who inject drugs. This is a statement from the U.S. Public Health Service in 2021, endorsing its use among persons who inject drugs. This is a statement from the International Antiviral Society, who reaffirmed their previous statement in 2022, indicating the use of PrEP for persons who inject drugs. And relatively hot off the presses, as of August of 2023, the U.S. Preventive Services Task Force included persons who inject drugs with who share paraphernalia or those with a known HIV positive injection partner should be considered eligible for HIV PrEP, in addition to those who are eligible based on sexual risk factors. Wisconsin Department of Health Services has adopted this recommendation as well in their 2022-2026 integrated HIV prevention and care plan. One of their primary goals is to prevent new HIV infections, and one of the ways to achieve that is to increase PrEP coverage from the current 19% to at least 50% of all people eligible by the end of 2026, and individuals who use drugs are one of their target populations. As you might imagine, there are a number of challenges in implementing PrEP among persons who inject drugs, which are unique to implementing it among persons who are eligible for PrEP based on sexual risk factors. And I think this PrEP care cascade published by Missler and colleagues in 2022 depicts this well. So first, we need our patients to be aware of PrEP and knowledgeable of PrEP. We need them to perceive some risk of HIV transmission to then go on to be willing to use PrEP. We need to have them provide them with ready access to PrEP care so then they can go on to use and adhere to PrEP. So what do we know about PrEP awareness and knowledge among persons who inject drugs? It's not great. So 20 to 30% or less, depending on the study, of persons who inject drugs are even aware of PrEP as a potential harm reduction strategy. Awareness is associated with higher degrees of educational attainment, participating in drug treatment programs, regular engagement in STI screening, sharing of paraphernalia, and engagement with syringe services programs. And the more knowledge individuals have, the more likely they are to use PrEP. Accurately estimating one's risk of HIV transmission is a real problem that's shown up in studies of PrEP linkage to care or PrEP access among persons who inject drugs. Appropriately, individuals who do not share paraphernalia, injection equipment, or have injecting partners do not perceive a risk of HIV transmission. But even among those who do have those risk behaviors, they have reported in qualitative studies that they believe HIV transmission is largely mediated by sexual risk factors. So there indeed is a gap in where we can educate our patients on their risk of HIV transmission. Willingness to use PrEP among persons who inject drugs is mediated by a lack of knowledge and risk perception. Among those who do perceive and recognize a risk, though, there is a strong interest in PrEP, and the possibility of injectable PrEP, which I'll introduce shortly, is very enticing to persons who inject drugs. We know regarding access to care that the HIV workforce is stretched thin, and that patients prefer care where they are. So whether that's in their medical home, whether that is within their syringe services program, or through accessing mobile units available through many health departments. There has been reluctance in some studies among primary care providers to prescribe PrEP to patients who inject drugs, which can further inhibit access to care as well. And we don't actually know much about PrEP use and PrEP adherence yet about individuals who inject drugs because the uptake is very low. Estimates suggest that 1 to 3% of persons who use injection drugs who are at risk for HIV are using PrEP. So these numbers are much lower than those with sexual risk factors, which certainly can be optimized as well. And because the uptake is low, we don't know a lot about PrEP adherence in this group of patients. However, in one study that showed good uptake of PrEP, adherence was optimized by frequent weekly check-ins, which I recognize is not feasible in many of our practice settings. So where I think we as providers can intervene in this cascade is we can help to make our patients more aware of PrEP, we can educate them on PrEP, and we can do our part increasing access to care. So I encourage you all to use ambulatory visits and hospitalizations as an opportunity to discuss HIV prevention and to consider incorporating PrEP prescribing in your practice to help expand access. Returning to the integrated HIV prevention and care plan from the state of Wisconsin, there are 3 strategies that were proposed to increase PrEP coverage. The first being expanding awareness of PrEP among primary care clinicians, including offering proper billing and coding procedures to ensure that patients are not charged, to increase the implementation of alternative PrEP options, such as cabotegravir, which is the bi-monthly injectable PrEP, and on-demand PrEP, which has only been studied and is only recommended in those at risk through sexual practices. And then expand the availability and accessibility of HIV post-exposure prophylaxis, including provider training or establishing a directory of PrEP prescribers that individuals can readily access. So part of my job today is to expand awareness of PrEP among primary care clinicians. So we'll spend some minutes on this now. You might be asking yourself which patients who inject drugs may benefit from PrEP. So if they have ever injected drugs, you should then ask yourself, have they injected within the past 6 months, or ask the patient if they've injected within the past 6 months. If yes, have they shared injection equipment? If yes, clearly eligible and would benefit from HIV pre-exposure prophylaxis. Also, if the answer to any of these questions is no, but the individual requests PrEP either on their own or after you having a discussion, they are eligible for PrEP. It's also important for you to assess sexual risk factors for HIV transmission among persons who inject drugs. We know that there are high rates of condomless anal and vaginal sex among male patients who inject drugs, higher rates among females who inject drugs. And then in the survey cited by the U.S. Public Health Service in 2021, 33% of HIV negative persons who inject drugs who were surveyed reported recent condomless sex with a partner who they knew to have HIV. So certainly still important to assess sexual risk as individuals who inject drugs who may not meet eligibility criteria I outlined on the previous slide may meet eligibility criteria based on sexual risk factors. The other population we shouldn't lose sight of in this discussion is transgender individuals who may be injecting things like steroid or fillers with an injecting partner or injecting them non-steroidally. Certainly, I would not consider this practice, injecting drugs in the traditional sense, but we know that rates of HIV are higher in transgender individuals, and certainly non-steroidal injection of steroids or fillers would place individuals at risk of HIV transmission, and they should be considered for PrEP as well. There are currently 3 available formulations of PrEP. The one that you're likely most familiar with is emtricitabine, tenofovir disoproxil fumarate, or Truvada. This is a once daily pill approved for persons who inject drugs in cisgender women, and I call that out because a newer formulation of emtricitabine, tenofovir discovy was only studied in or excluded individuals at risk of HIV transmission from receptive vaginal sex, so is not approved for cisgender women. The other difference to make note of between Truvada and Discovy is that Discovy is preferred for patients with renal dysfunction. And then the newest PrEP option we have is cabotegravir, which is an every other month injectable. This, like Truvada, is approved for cisgender women, but owing to the relatively new nature of it and the cost, implementation is quite limited at this point. I show this slide not to overwhelm you, but to simply demonstrate that there are well-established baseline and interval screening and laboratory monitoring recommendations should you choose to integrate PrEP prescribing into your practice. And these are now available in a very easy to use ambulatory pathway available on UConnect that I will take a moment to share with you very briefly. This ambulatory pathway just went live 2.5 weeks ago, championed by Rose Staden in our HIV clinic, who's one of our primary PrEP prescribers, but also with collaborators from addiction medicine, family medicine, and internal medicine. So I am hoping to navigate seamlessly to this ambulatory pathway to share it with you all. And I believe now you should be viewing another screen here, the ambulatory pathway for HIV PrEP prescribing. So to take you through this briefly, an adult patient, this applies to only those 18 years or older, presents to primary care with concerns for HIV acquisition. The first step is to assess both their sexual and injection drug risks for HIV transmission. If they do not meet these eligibility criteria, but again, request PrEP specifically, they should be considered eligible. Then we go on to assess if this individual is eligible for PrEP prescribing in primary care. And there are criteria listed here for daily oral PrEP use as well as injectable PrEP use. The thing I will highlight is that it's important to assess both from a laboratory standpoint as well as a clinical standpoint for current HIV. And in that very early window, any symptoms of acute HIV should prompt repeat laboratory testing before prescribing PrEP. If they do not meet these criteria for prescribing in primary care, but you still think they're a candidate, you can refer them to our PrEP navigator who can connect them with our PrEP clinic. And then the pathway goes on to describe the nuances among the 3 PrEP options, as well as recommended laboratory, immunization, patient instruction, and follow-up instructions for individuals. So of course, we can't go over this in detail, but again, this is available on UConnect in the ambulatory pathways section. The other important thing to be aware of is that Rose Staden Included in this ambulatory pathway, but also separate from it, has a PrEP management smart set that you all can access, where it can prompt consultation to our PrEP navigator. It offers pre-templated progress notes, initial and follow-up labs, immunizations, drug orders, diagnosis and billing codes, and patient follow-up and instructions. Importantly, I wanted to address some coding issues because it can really influence one's access to PrEP. The Affordable Care Act requires coverage of HIV prevention services. So very few patients have any issues accessing the medication at little to no cost. But where we do see patients incur costs is with laboratory monitoring, and this can be quite expensive. So to avoid patients are incurring these costs, our PrEP navigator recommends use of these two diagnosis codes. The first only through the end of 2023, Z20.6, and then beginning January 1st, she anticipates payers to reimburse based on the diagnosis code Z29.82. Take a screenshot of this if you're interested. Our PrEP navigator is Katie Childs down in the HIV clinic. She's happy to address any specific questions through a consult to PrEP navigation or through her email, which is available there. And then finally, just to highlight the importance of connecting our patients with substance use disorder treatment. Medication for opioid use disorder, that is buprenorphine, methadone, extended release naltrexone. In the ID literature, we know it improves adherence to antibiotic therapy. It decreases the likelihood someone will discharge before medically advised. It reduces readmission, and there's a mortality benefit among patients with opioid use disorder. This is a map here on the right of the state of substance use treatment providers in 2019. However, with the passage of the Mainstreaming Addiction Treatment Act, or the MAT Act, as part of the omnibus bill in Congress this year, now any DEA registered prescriber can prescribe buprenorphine, and it removes any previous caps on the number of patients that can be cared for by any individual prescriber. So hopefully, over the coming years, this map would turn much more blue, indicating greater access to substance use treatment. And then finally, I just want to highlight some ongoing work in this space. I shared with you Dr. Rosemary Bailey's project. I also have the privilege of advising Dr. Haley Probst, who's a current PGY3 internal medicine resident, who is doing quality improvement work to improve contingency planning for patient-directed discharge, or AMA discharge, among persons who inject drugs who are admitted with serious infections. Dr. Brittany Weichman, who's a PGY2 infectious disease pharmacist, is evaluating the outcomes of persons who inject drugs with serious injection-related infections when treating with long-acting liporegulpeptides, iridovancin and dalbavancin, the once-weekly antibiotic injectables. And she's collaborating with Dr. Luke Malik, who's one of the lead infectious disease pharmacists at Meriter Hospital, who they're looking at easing access to oral antibiotics for persons who inject drugs at the time of patient-directed discharge. So to summarize, substance use disorder and its complications are increasing. Persons who inject drugs face several barriers to care when seeking care, including stigma and negative provider interactions. Person-first language should be used to avoid triggering biases. Educating our patients on harm reduction can reduce risk of infection, and HIV PrEP is indicated for many persons who inject drugs. A quick acknowledgement of many of my collaborators and those who support this work. And then I recognize what little time we have left for questions, but I'm also quite happy to take any offline, and my email address is there.
Great. Well, thank you, Jessica. That was a wonderful overview and really eye-opening for a world that we should all be much more comfortable dealing with. There are a number of questions, but we just have 1 minute, so I'm going to kind of summarize or ask on the inpatient setting, what is our role in initiating some of these harm reduction maneuvers and from that transition from inpatient to outpatient? do we start prep? What do we?
That's a great question. So what I can share with you is that, I think if patients are open to that counseling, it is an ideal time to have these sometimes difficult discussions. Often this serves as, somewhat of a wake-up call for people who are admitted to the hospital, particularly for those who, are in the hospital for many weeks adhering to a first-line antibiotic regimen. There is a current effort among our addiction medicine colleagues to actually start PrEP while someone is inpatient, contingent on the ability to connect them to a provider who is comfortable continuing that prescription outpatient. So I suspect you will see that occurring more, certainly relevant to select patients. But yes, if someone is willing to do that and open to the conversation, then I think it's a great time to have it.
Great. All right, well, there's a number of questions in the Q&A. I encourage all of you to reach out to Dr. Tischendorf outside of Grand Rounds, because we are 1 minute over the hour. I want to respect everyone's time. Thank you. Thank you again, Jessica, for a wonderful overview and eye-opening discussions. And I hope everyone has a great day and great weekend.